Hi, this is Professor Villanova, and I'm going to be covering the NSG 434 Topic 1 content. And in Topic 1, we have three subjects. The first one is pediatric assessment, the second one is integumentary dysfunction, and the third one is childhood immunizations. You're probably going to see multiple recordings to accomplish all of these content and lectures, but I just wanted to give you a heads up that we're starting with number one here now. So we have our objectives, and the objectives cover the pediatric assessment, numbers 1 and 2, and then we move into integumentary disorders or dysfunctions, and that's topics number 3, and then numbers 4 and 5 have to do with immunizations, that is specifically childhood immunizations, and the last objective has to do with the MedMath calculations, as you will be taking your MedMath PBA during the second day that the 434 course meets. Communication is the first item on the agenda for the physical assessment. Obviously, we have to be able to communicate with the parent's caregiver as well as with the child. And for the sake of pediatric nursing, the client is considered the child and the parent's caregiver, whoever is there attending to that child. They come as a package deal, and we need to address and meet both the parent's caregiver as well as the child's needs. If you remember from NSG 310, we talked a lot about communication and the fact that every communication has two parts to it. It has what is being said, and that's the verbal part, and it also has what is the behaviors, what are the actions. That is considered the nonverbal part of the communication. So we need to take both parts of that into consideration. Additionally, it is important to tune into and pay attention to what is not being said, because what is not being said is just as important as what is being said. So watch for those clues, watch for those signals, watch for those verbal leads, watch for child behavior, how they react, how they respond to their parent or caregiver who's there with them, as well as how they respond to the healthcare provider, that is you, the nurse, or the nursing physician or physician's assistant that may be there. Another concept that is listed here on the slide is providing anticipatory guidance, and anticipatory guidance has to do with the ideal way to handle a situation before it becomes a problem. An example of anticipatory guidance is we have a patient who has been diagnosed with leukemia, and the child is going to be receiving chemotherapy and most likely will encounter hair loss. So to give the child information about hair loss, what it'll be like, when it may occur, and what are some of the things that can be done. They may choose to have their hair completely shaved before it starts falling out in clumps. They may choose to go ahead and start buying some really cool hats or caps to be wearing. That is important to provide the child as well as the parent or caregiver this information ahead of time so that they can start to process it, to think about it, to assimilate it, and to be able to ask questions and to be able to start to take some action before it becomes a problem. That's about all I have to add about the communication piece there. Moving forward then, specifically, communicating with children is a bit different than communicating with an adult. Remember, the child does not have the benefit of the life experiences that the adult may have. So, their ability to communicate is going to be influenced by their life experiences as well. Infants usually have an experience of stranger anxiety. In other words, they are anxious around someone that they do not recognize or they are not familiar with, and that is called stranger anxiety. But to respond to the child, with gentleness, that is, with a calm and a quiet voice. We don't want to be raising our voice and speaking loudly to them. We don't want to be becoming anxious ourselves and our voice pitch escalating. Also, play for the infants and younger children is really important. It is their work, it is their method of communication and expressing their feelings and what is going on inside of them. Because remember, they don't have necessarily the vocabulary at this age to be able to put into words what they're thinking and what they're feeling. Children younger than 5 years old are essentially egocentric. In other words, the whole world exists and evolves around them. Everything is about me. It is all about I. And they see only things from their point of view. So it may be difficult for them to appreciate, how someone else is feeling. That's why sharing doesn't really come into play till almost, they're getting into school age, kindergarten and first grade, when they're able to start thinking beyond themselves and sharing with somebody else. Also, think about phrases that we're using. The example in your PowerPoint notes talks about the fact that if we tell a child that, we're going to give them a shot and that it's going to feel like a stick in their arm, they're going to visualize a real stick, a twig from a tree that is in their arm because they are very literal. Maybe to equate it to something that they may be familiar with, to say that it'll feel like a little pinch, or it may feel like a bee sting. Those are things that they've experienced and maybe they can relate to. Let's see, what else do I want to say here about it? School-age children are very, very into body identity, body integrity, and their personal self, what they look like. And they're very sensitive and they're easily threatened. It's important that we understand that and we appreciate that they're very body conscious. In other words, they may be concerned that if they have blood coming out their arm, all of their blood is going to come out their arm because of that puncture or that wound that they have received. Now, the adolescent, that's a different story. Adolescents tend to fluctuate between childhood and adult. 1 minute, the adolescent you're talking to and working with could be very mature, and you think, my goodness, this is easy. They're just like an adult, a young adult in their 20s or 30s. And then it's a matter of you turn around and it's like flipping the light switch. Suddenly they're performing or acting, their behavior is similar to a 2-year-old or a toddler. And that's not uncommon. That is a part of adolescence, that oscillating between adulthood and childhood. So no single approach can really be consistently used with this age group. You really have to be able to think on your feet and, move with whatever the situation presents. Overall, with kiddos, try to avoid sudden, rapid advances. Warm up to them, compliment them on their shoes. Hey, I really like the way those shoes light up when you walk. Or, oh, I see you're wearing, your favorite hero T-shirt. Well, tell me about your favorite hero. What is it you really like about him? But things like that really helps to engage them as you then are able to move closer to them. Because obviously, with physical assessment, you're going to have to put your hands on them and touch them. But you don't want to just walk up to them and start touching them. You need to have that time to establish rapport. Eye contact is important. Smiles are important. Talk to the parent initially. That usually helps to break the ice with the child, because the child, again, will take their cues from how the parent is interacting. Also, if the child has a transition object. Transition object is also called comfort item, and that could be a doll, a puppet, a stuffed animal, a blanket. And some of you, this may bring smiles to your face, remembering that favorite stuffed animal or blanket that you carried around forever. And, you may even have a part of it tucked away somewhere in the items that you brought to campus. So The bottom line, transition objects, those are really important to the kiddos. Don't take them away. I've taken many a kid into the OR clutching their favorite stuffed animal until we've been able to have the child adequately sedated. And then the stuffed animal leaves the room or goes back onto the cart. But the bottom line is, as far as the child remembers and knows, that stuffed animal was with them in their arms. And then I've been very aware to make sure that that stuffed animal is back in their arms so that when they wake up in recovery, they've still got their stuffed animal that they're clutching. And they never know the difference, but yet that is a huge, huge comfort. It helps, it is a transition object. It helps to change for them when they're changing from one situation or environment to another. That's why it's called transition. Let's see. Older children, it's better to talk to them without the parents present. And usually when I'm working with adolescents, I'll ask them, you know, do you want your mom or your dad or your grandma, grandpa here, or would you prefer to, you know, for me to perform, you know, to go about this assessment without them present? And it's also important to give the child that privacy too, because they may have something they want to share, or they may have a curiosity about something but be uncomfortable around their parents, but yet feel a certain element of comfort in approaching the nurse. So that's important as well too, the privacy for the child. Again, assuming eye level. So, you know, kids are short, and, you know, be sure to get down to their level. Don't be standing towering over them at their bedside. Get down to their level. I have conducted many an assessment sitting on the floor with a child, and, you know, that is their world, that is their level, and that is much less threatening than trying to stand over them. Again, being quiet, calm, unhurried, and confident is really important, and use simple words. This is the time to keep it simple, silly. Don't be trying to use medical terminology, and don't think, oh, you know, the parents are going to think I'm a real idiot because I'm talking so simplistically, but that's important for the child. And also using short sentences. We don't want to use complex, compound sentences. Just use very short, very brief, very direct and to the point. Again, honesty is really, really important with kiddos. They can see right through us like a glass wall. They know if we're, you know, if we're painting a picture that isn't exactly truthful, and they'll call us on it. So be very honest and very truthful. And also, especially, allow the child to express their concerns and their fears. They may be fearful of the monsters under their bed. Allow them to talk about it, express it, and maybe, you know, crawl under the bed with them and look for those monsters and put a light on in the room until they fall asleep. You know, I've even gotten out the vacuums at times when I've done home health care, and, you know, we're going to vacuum those monsters up. And, you know, that really, you know, helps them to feel that, you know, that they're respected and that they're important. Moving on to history taking. In your textbook is box 29.3, and that has a list of all the information that can be gathered in a health history. So I'm not going to go through each and every piece, but do be sure to pay attention to the box 29-3. The informant is anybody who is providing the information. So, you know, it could be the person who is, you know, the actual patient, a child. It could be the informant. It could be a parent. It could be a grandparent, a caregiver. And then second of all, we want to assess and evaluate the impression of reliability and willingness to communicate. Because sometimes if there is a hesitancy or some faltering, we may need to be concerned about that. Also, special circumstances, which would involve an interpreter. If the child does not, if English is not their primary language, we are required by law to provide an interpreter in their tone language that they're familiar with. Chief complaint is specific reason. What brought you here today? Focus on the present illness, all factors, even if they've disappeared or changed since their onset. So it may be that they had a fever 2 days ago, but now the fever is gone. But the fact that they had a fever 2 days ago, that's an important symptom of their illness that we're obtaining information about. Well, I'm about to run out of time here, so I'm going to stop right now, and we'll have a part two of physical assessment then. So watch for that tape. Thanks for your attention. Catch you on part two.